Hi guys, welcome to your first online pharmacology lecture. So thank you first and foremost for being so patient with us. It's definitely been a learning experience, lots of trial and error. So one thing, I'm going to keep this video pretty short and to the point because we've learned that after about 30 minutes or so, your video begins to lag and you have a lot of issues. So hopefully we'll get this going. It's a really short chapter, like 7 pages, super basic, to the point information, okay? So today we're going to talk about pre-operative medications. So first and foremost, when you have a surgical patient, they're always going to need a pre-op evaluation. You have to do this in order to know what they're actually having done, what past issues they've had, or any kind of underlying medical conditions. COPD. Why is that important to know if your patient has COPD? Because it is literally a chronic obstruction of pulmonary. So that means that a lot of the medications that are given can potentially affect their breathing. So that's a big deal. Allergies, any past allergies to medications, current medications they're taking. Why is that important? Basic stuff, if they're taking aspirin or they've taken BC or anything, it's going to have a reaction, okay? Even if it's not a physical action they can see, it can also be a systemic action, okay? Blood clotting factors, that's a systemic action. Okay, they're always going to assess the airway. Why? Because who is harder to intubate? Obese patients, people with a thicker airway, okay? They have to be able to assess to make sure, am I going to be able to intubate this patient if I need to? And anesthesia history. Why is anesthesia history important? Because if they have had issues in the past, that will show up. Potential MH, that's another one. So the person that conducts this pre-op evaluation is almost always a CRNA. It is an anesthesia provider of some sort. Each state has their different regulations. Most of the time, it's going to be a CRNA. You can have an anesthesiologist that does it as well, but that's not as common. But anesthesia will be the person who performs the questionnaire and the pre-op evaluation. Okay, moving on to our first of 4 categories, your sedatives. So when you give a sedative, yes, it's going to make you sleepy and want to take a nap, but the reason that sedative is making you do that is because it is reducing your anxiety. It is relaxing you. Okay? Some sedatives, giving at different doses, can actually cause different forms of amnesia, antegrade or retrograde, depending on the dosage. Okay? So, one of the most common medications given as a sedative is your benzos. So, what I want you to know, Versed is the most commonly used benzodiazepine in surgery, okay? Y'all are always going to hear about that. What I want you to know is your trade and generic name. So your trade names and your generic names. Versed, midazolam, Valium, diazepam, Ativan, lorazepam. They're all PAMs or LAMs, okay? The way some students have remembered that in the past is a lamb is sweet and I want to count them when I go to sleep. A sedative, okay? Always know medications. I cannot instill this enough. Medications are almost always going to be milligrams per kilogram of weight, okay? So this is super basic stuff. Moving on to your second category, analgesics, pain relievers, right? So when it comes to certain patients, some are going to need more analgesics than others. Analgesia literally means without pain. Okay? I think that was actually one of your questions I gave you. So, when it comes to certain patients, say you have a patient who is going to need a Foley or a central line or any kind of monitoring, a lot of times they're going to give them an analgesic because, first of all, where's that Foley going? Into the urethra. That's going to be a little painful. So you're going to want to have some kind of relaxation and pain relief, okay? That's the main thing. You don't want it to hurt when you get a Foley. So when you use analgesics, we've talked about this before. The good thing about using them is it kind of reduces that amount of anesthesia that's required for the patient, okay? The less pain they're in, the less they're going to draw up, constrict, have muscle movement. It affects a lot of different things. The bad or the con of using a lot of analgesics is, that's my dogs, is depending on how many you give or how high the dose is, it can actually slow your respirations. So those patients that do have COPD or who have chronic lung issues, that's something they're really going to have to monitor. Anyone that's ever had surgery or who has had to take a lot of pain medications, you're going to know it reduces intestinal motility. What does that mean? Makes it hard to use the bathroom. Can't poop, okay? So a lot of these patients may be getting pain relief, but one of the post actions that comes along with it is not being able to use the bathroom, which can kind of have awkward side effects too. So a subcategory of the analgesics are opioids. So morphine. Morphine is one of the most commonly used post-op analgesics, okay? Some people don't tolerate morphine very well, but the thing to remember about morphine, it is the most common natural type of opioid, okay? I want you to know the different names associated with morphine: Astromorph, Duramorph, okay? Those are the other names for morphine. That comes up a lot on your boards. They try to trick you with that. Another really common drug, it's the most common synthetic. So morphine is the most common natural. The most common synthetic is mepridine or meperidine, however you want to say it, also known as Demerol. Everybody knows about Demerol. One of the drugs that you probably are going to hear a little bit about, it's really common, they're trying to regulate it more, is fentanyl. The other name for fentanyl is Sublimase. That's important. That shows up on your boards a lot. So fentanyl is very, very, very highly addictive, okay? It has a pretty fast onset, so you have to be very cautious with fentanyl. So one thing I want you to remember whenever it comes to analgesics and any kind of medication that we've talked about before, remember the faster the onset, the shorter it really works. It has a shorter duration. So on page 177, it talks about morphine, Demerol, and their times and peaks. So I really want you to pay attention to that. So morphine is about 2 to 5 minutes for its onset, and it peaks out at about 10 to 15. So that's relatively short. Once you hit that peak, you really have those lasting effects for a couple of hours. When it comes to your Demerol is pretty quick if it's given IV. So you get about 1 to 3 minutes. That peak is 5 to 20-ish. Normally they say about 15. And it normally provides that pain relief for about 3 hours. It says 2 to 4 hours, but normally it's around 3. So moving on to our third category. Okay, sorry. Back to our categories. So now we're going to talk about those anticholinergics. So anticholinergics have the ability to block the effects of the parasympathetic nervous system. So that's how you get, number one, you're blocking those neurotransmitters of acetylcholine. Okay, that's important. I think that was one of the questions I gave y'all. Another thing to remember about anticholinergics. So before we've talked about the vagus nerve and how you can do like a vagotomy to sever the branches leading to the stomach, because with a vagotomy, it stops that over sensation of secreting gastric acids and all kinds of different things. Okay, so instead of having to do a vagotomy, a lot of times if it's for short use, they use anticholinergics to block that response. So a couple of cool things that I wanted to talk about is that response you get from the vagus nerve when you're stretching on the peritoneum. So say you're doing a big open belly case, you're pulling that peritoneum, that's going to affect vagus stimulation. Also, a lot of times if you are messing with the peritoneum, you're messing with any of the ocular muscles, you're actually going to have a resulting effect of a decreased heart rate. It's going to start to drop down a little bit. So that's pretty cool. I think that may be one of your questions I asked. I cannot remember. So a lot of times they can interchange anticholinergic and antimuscarinics or muscarinics, however you want to say it. So the thing to remember is it's drying up or reducing these secretions, okay? That's the main goal of anticholinergics. The very go-to drug that you're going to hear about is atropine. So atropine has an almost immediate onset. That's why they use it a lot. When it comes to atropine, this has kind of changed over time. Now they have other, I guess it would be the trade name, but it's atropine, but it's the same. Atropine will most of the time be your trade and your generic name. So that's one of your questions that I gave you. Atropine will most of the time be known as your trade and your generic name. So when it comes to other different options for an anticholinergic, scopolamine, we've talked about this before, it kind of falls under a couple of different categories. It can be considered an antiemetic, which prevents what? Emesis, throwing up. It can reduce that mucus secretion, and it can also make you a little sleepy, a little drowsy. So it falls under the sedative category as well. You can also use what is called glycopyrrolate or Rubinol. Rubinol is the name, okay? That might trip you up. So anytime you see medications with the generic and the trade name, make sure you're learning both of them. That's important. Okay, moving on to one of our last categories, your gastric agents. Okay, so we always talk about surgical patients being NPO. They're kind of going away from that a little more. They don't necessarily rely strictly on that rule, but it's still a really good thing to go by, in my opinion, because when patients are NPO, it's definitely going to reduce risk of aspiration. Nothing's going to come up if there's nothing in there, okay? They tell you even if you're chewing gum, that is going to increase the gastric fluid volume in your stomach. so it can still make you aspirate in surgery. So they're not being jerks, they're just trying to keep you from choking to death. So when it comes to your reflux or your regurgitation, what's happening is that patient's lower esophageal sphincter that we learned about in anatomy starts to relax. Once that relaxes, all that fluid is coming up. So that's why a lot of times you will give what? Cricoid pressure. That pressure right there is going to constrict and push down so that they're not able to emit anything. Okay, so some of your gastric agents, antacids, these are basic over-the-counter kind of things that you can use. When it comes to normal gastric acid, it's about 2 to 3. So very acidic, right? If you're on a scale, you have 2 to 3, very high acidity. You start to get to your bases, about 7, right? Bases are going to diffuse that. So a lot of your gastric antacids are going to work as a base almost. So one of the main go-tos, if you are having any kind of gastric regurg or inflammation trying to come up, they're going to use sodium citrate by Citra, okay? Easiest thing, you can go to Walmart and buy this. So a couple of other things that are options too are your histamine receptor agents or antagonists. So H2 blockers. When it comes to this actually prevents the acid production. It doesn't stop it once it's already started. It's really there to stop it before it becomes an issue. So Pepcid and Zantac, those are go-tos. People that are having allergic reactions can also use Pepcid to help lower that reaction. So like little kids, when they're having hives, this just happened to us recently over the break, since it is a histamine blocker, it can be given to reduce any kind of hives, irritation, swelling. So Pepcid is a good go-to. If you don't have Benadryl, try Pepcid. It may work. Okay, moving on. So next on your gastric agents, we're going to talk about proton pump inhibitors. So this is actually pretty interesting because your PPIs are working in that final stage, okay? They're trying to prevent the release of hydrochloric acid. So all of that gastric acid inside there, it's breaking it down at the final stage. So this is an easy go-to for GERD. A lot of people will take Nexium. Nexium is the PPI of choice. So if you're ever having severe reflux or GERD, try some Nexium. It may take it a day or two to start working, but it will. Next, antiemetics or gastrokinetics. So we talked about emetics, emesis, throwing up. So the point of using an antiemetic is to prevent or reduce post-op nausea and vomiting. So Zofran, everybody's pretty much heard of Zofran. Ondansetron, or Dazatron, my bad. Ondansetron. I don't know why I said that. So anyways, that is your most commonly used antiemetic for pre-op patients. You also have what's called Anapsin or droperidol. So the thing about that is you really have to be aware of the black box warning that comes along with that. So it has a black box warning because it can actually affect your QT intervals. So does anyone know what that is? Your QT intervals are actually your QR wave. So think about your heart rhythms. So that is a very important drug to kind of watch out for. You also have Reglan. Reglan is a little different because it actually is to kind of flush it out instead of preventing it from coming back up. It's trying to increase gastric emptying so that you are able to dispel all of those gastric acids instead of letting them come back up. It wants it to go down. So, with all that being said, I don't know how helpful that was, but I will be able to answer any questions you have, and I promise next time I will have it a little more together. This has just been a very interesting trial and error session for me. So hopefully next time I'll be much more prepared. I hope to see you guys soon, and if you need anything, please email or text me.